Good evening, delegates and all the participants. Thank you for joining. Today we are back with our series, The Icons in Conversation with Dr. Ritu. Myself, Sahiti from Shield Connect, welcoming you all for today's webinar on endometriosis associated infertility. So it's my privilege to introduce Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMR-COG. Ma'am is the consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, and ma'am has been the infertility specialist and NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am, and I hand over the session to you.
Yeah, thank you, Sahiti. And thank you, Shield Pharma, for providing the platform. So, a warm welcome to all of my dear friends all across the geography. Now, this is the first session of the 2024. So, to start this session of this is the knowledge sharing sessions. For this first session of the 2024, I invited my very dear friend, Dr. Shadi Salim, who is full of bundle of knowledge. He is always ready to share his knowledge. So first I will give his introduction. Dr. Shadi Salim is consultant of Ops and Gynec and IVF, president of Arab Society of Fetal Medicine and Surgery, chief board of Neo Cleopatra Women Health Center, ICOG mentor, board member of the World Cosmetic Gynecological Society, coordinator of the Fetal Medicine and IVF diploma, and he's an international speaker. So a very, very warm welcome to you, Dr. Shadi. And today the Dr. Shadi is going to discuss with us a very important topic regarding the endometriosis and infertility. Friends, as we all know, related to endometriosis, we all are getting lot of patients, and there are so many queries in everyone's mind. Yes, if there is an endometriotic cyst, how can we do the stimulation? And even though the patients also have a lot of confusion in their mind, ma'am, we are having a big endometriotic cyst. If we go for the IVF, is it correct that you are able to do the oocyte retrieval or not? And how much is the success rate? So a very, very warm welcome to you. And once again, a welcome to my all dear friends who have joined all across the geography. Very happy to see some of my dear friends. Over to you, Dr. Shadi. Post your lecture, we will take some questions.
And many thanks, my dear Dr. Ritu, for your invitation. And I am very happy to be with you in your programs. Every time I am very happy to be with you.
Warm welcome. Namaste. We say namaste.
Most welcome.
Yeah.
Most welcome, my dear friends. Today we will talk about the guidelines, ISHRI guideline about infertility associated endometriosis. Firstly, we want to define what is endometriosis. Endometriosis is defined as a disease characterized by presence of endometrium-like epithelium and or stroma outside the endometrium and the myometrium, usually with an associated inflammatory process. Also, we must know the difference between endometriosis and adenomyosis, as adenomyosis is a special type of endometriosis, which is defined as presence of ectopic endometrial tissue, endometrial stroma and glands within the myometrium. How we can diagnose endometriosis? Endometriosis can be diagnosed in individuals presenting with the following cyclical and non-cyclical signs and symptoms as dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding or hematuria, shoulder tip pain, catamenial pneumothorax, cyclical cough and or hemoptysis and or chest pain, cyclical scar swelling and pain, fatigue, and infertility. Clinicians are recommended to use imaging, ultrasound, or MRI in the diagnostic workup for endometriosis. At the past, laparoscopy is the gold standard in the diagnosis of endometriosis, but now the gold standard of diagnosis of endometriosis is vaginal ultrasound. But they need to be aware that a negative finding doesn't exclude endometriosis. If you use vaginal ultrasound, if you don't find anything, this cannot exclude endometriosis, particularly if there is presence of peritoneal, superficial peritoneal endometriosis. In patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, clinicians should consider offering laparoscopy for diagnosis and treatment of suspected endometriosis. We talk in our lecture about two items. The first one is treatment of endometriosis-associated pain, and the second item is treatment of endometriosis-associated infertility. So we talk about the first item, how to treat endometriosis-associated pain. The first thing, we can offer giving analgesics. Women may be offered non-steroidal anti-inflammatory drugs or other analgesics, either alone or in combination with other treatment to reduce endometriosis-associated pain. The second thing, we can offer hormonal treatments. It is recommended to offer women hormone treatment, combined hormonal contraceptive pills, or progestogens, or gonadotropin releasing hormone agonist, or gonadotropin releasing hormone antagonists, as one of the options to reduce endometriosis-associated pain. Combined hormonal contraceptives, it is recommended to prescribe women a combined hormonal contraceptive, either oral, vaginal ring, or transdermal, to reduce endometriosis-associated dyspareunia, dysmenorrhea, and non-menstrual pain. Women suffering from endometriosis-associated dysmenorrhea can be offered the continuous use of combined hormonal contraceptive pill. Progestogens, including progestogen-only contraceptives. It is recommended to prescribe women progestogens to reduce endometriosis-associated pain. Strong recommendation that clinicians take the different side effect profile of progestogens into account when prescribing them. It is recommended to prescribe women a levonorgestrel releasing intrauterine system or an etonorgestrel releasing subdermal implant to reduce endometriosis-associated pain. Gonadotropin releasing hormone agonists. It is recommended to prescribe women gonadotropin releasing hormone agonists to reduce endometriosis-associated pain, although evidence is limited regarding dose or duration of treatment. Strong recommendation that gonadotropin releasing hormone agonists are prescribed as a second line. For example, if hormonal contraceptives or progestogens have been ineffective due to their side effect profile. Clinicians should consider prescribing combined hormonal add-back therapy alongside gonadotrophin-releasing hormone agonist therapy to prevent bone loss and hypoestrogenic symptoms. Gonadotrophin-releasing hormone agonists, it's recommended that gonadotrophin-releasing hormone antagonists are prescribed as second line to reduce endometriosis-associated pain if hormonal contraceptives or progestogens have been ineffective due to their side effect profile. Aromatase inhibitors. In women with endometriosis-associated pain refractory to other medical or surgical treatment, it is recommended to prescribe aromatase inhibitors as they reduce endometriosis-associated pain. Aromatase inhibitors may be prescribed in combination with oral contraceptives, progestogens, gonadotrophin-releasing hormone agonist, or gonadotrophin-releasing hormone antagonist. Lastly, we talk about treatment of endometriosis-associated pain by surgical treatment. Surgical treatment is recommended to offer surgery as one of the options to reduce endometriosis-associated pain. When surgery is performed, clinician may consider excision instead of ablation of endometriosis to reduce endometriosis-associated pain. Laparoscopic uterosacral nerve ablation is not beneficial as an additional procedure to conventional laparoscopic surgery for endometriosis, as it offers no additional benefit over surgery alone. Perisacral neurectomy is beneficial for treatment of endometriosis-associated midline pain as an adjunct to conventional laparoscopic surgery, but it should be stressed that perisacral neurectomy requires a high degree of skill and associated with an increased risk of adverse effects such as intraoperative bleeding and post-operative constipation, urinary urgency, and painless first stage of labor. When performing surgery in women with ovarian endometrioma, clinicians should perform cystectomy instead of drainage and coagulation, as cystectomy reduces recurrence of endometrioma and endometriosis-associated pain. When performing surgery in women with ovarian endometrioma, clinicians can consider both cystectomy and CO2 laser vaporization, as both techniques appear to have similar recurrence rates beyond the first year after surgery. Early post-surgical recurrence rates may be lower after cystectomy. When performing surgery for ovarian endometrioma, specific caution should be used to minimize ovarian damage. Clinicians can consider performing surgical removal of deep endometriosis, as it may reduce endometriosis-associated pain and improve quality of life. A total hysterectomy is done if pain relief was unsuccessful, but doesn't guarantee total pain relief. Hormone replacement therapy should be discussed with patients. Medical therapies after surgery, it is not recommended to prescribe preoperative hormone treatment to improve the immediate outcome of surgery for pain in women with endometriosis. Strong recommendation that women may be offered post-operative hormone treatment to improve improve the immediate outcome of surgery for pain in women with endometriosis, if not desiring immediate pregnancy. Medical versus surgical treatment for endometriosis. It is recommended that clinicians take a shared decision-making approach and take individual preferences, side effects, individual efficacy, costs, and availability into consideration when choosing between hormone treatment and surgical treatment for endometriosis-associated pain. Non-medical management strategies. It is recommended that clinicians discuss non-medical strategies to address quality of life and psychological well-being in women managing the symptoms of endometriosis. Non-medical intervention include Chinese medicine, nutrition, electrotherapy, acupuncture, physiotherapy, exercise, and psychological interventions to reduce pain or improve quality of life measures in women with endometriosis. Now we talk about the second item of our lecture. The first item is how to treat endometriosis-associated pain. Now we talk about treatment of endometriosis-associated infertility, as there are two main problems for endometriosis. The first one is pain, and the second one is infertility. So we talk about both items in our lecture. In infertility, women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility. A strong recommendation that women seeking a pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rate. Those women who can't attempt to or decide not to conceive immediately after surgery may be offered hormone therapy, as it doesn't negatively impact their fertility and improves the immediate outcome of surgery for pain. In infertile women with endometriosis, clinicians should not prescribe anti-inflammatory drugs or letrozole outside ovulation induction to improve natural pregnancy rates. Yeah, only we can prescribe letrozole if the lady wants to get pregnant. A strong recommendation that operative laparoscopy could be offered as a treatment option for endometriosis-associated infertility in revised ASRAM stage 1 and stage 2 endometriosis, as it improves the rate of ongoing pregnancy. Clinicians may consider operative laparoscopy for treatment of endometrioma-associated infertility, as it may increase the chance of natural pregnancy in a specific condition. It's recommended that the decision to perform surgery should be guided by the breast. This is very important point. If the lady with infertility and you see the endometrioma in these ladies seeking for pregnancy, please don't touch. We can touch endometrioma by laparoscopy in a specific condition. What about this specific condition? We can take a decision of laparoscopic removal of endometrioma according to this specific condition: presence or absence of pain symptoms, patient age and preferences, history of previous surgery, presence of other infertility factors, ovarian reserve, and estimated endometriosis fertility index. women should be counseled of their chances of becoming pregnant after surgery to identify patients that may benefit from ART after surgery. The endometriosis fertility index should be used as it is validated, reproducible, and cost-effective. The results of other fertility investigation as the partner sperm analysis should be taken into your consideration. Medically assisted reproduction in ladies with endometriosis. In infertile women with revised ASRAM stage 1 and stage 2 endometriosis, clinician may perform intrauterine insemination with ovarian stimulation instead of expectant management or intrauterine insemination alone, as it increases pregnancy rates. ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised. If there is a male factor infertility in case of low endometriosis fertility index, or if other treatments have failed. A specific protocol for ART in women with endometriosis cannot be recommended, as both gonadotrophin releasing hormone antagonists and agonist protocols can be offered based on patients and physician preferences, as there is no difference in pregnancy rate or live birth rate between both protocols. As the past, we used the ultra-long agonist protocol, but now there is no difference. We can use antagonist protocol or agonist protocol for cases with infertility associated endometriosis. For me, I use only antagonist protocol for more than 10 years for all ladies. Women with endometriosis can be reassured regarding the safety of ART, since the recurrence rates are not increased compared to those women not undergoing ART, as their ladies may ask us about if the lady take induction of ovulation. This can increase the recurrence rate of endometrioma. The answer, no. There is no increase in recurrence rate after induction of ovulation. In women with endometrioma, clinicians may use antibiotic prophylaxis at the time of oocyte retrieval, although the risk of ovarian abscess formation following follicle aspiration is low. There is insufficient evidence to recommend prolonged administration of combined oral contraceptive pills or progestogens as a pre-treatment to ART to increase live birth rate. So please don't use hormonal contraceptive pills before you start in the induction of ovulation protocol to do IVF. Clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in women with revised ASRAM stage 1 and 2 endometriosis, as the potential benefits are unclear. Clinicians are not recommended to routinely perform surgery of ovarian endometrioma prior to ART to improve live birth rate, as the current evidence shows no benefit, and surgery is likely to have a negative impact on ovarian reserve, as if you do cystectomy, you must remove a part of ovarian tissue, And after the operation, ovarian reserve will decrease. So, from my point of view, please, if the lady complaining of infertility, don't touch endometrioma. Go directly to IVF without removing endometrioma by laparoscopy. Surgery for endometrioma prior to IRT can be considered to improve endometriosis-associated pain or accessibility of follicle if the ovarian reserve is very high and there is no previous ovarian surgery and good amount of antral follicle count. The decision to offer surgical excision of deep endometriosis lesion period to ART should be guided mainly by pain symptoms and patient preferences, as its effectiveness on reproductive outcome is uncertain. Fertility preservation. In case of extensive ovarian endometriosis, clinicians should discuss the pros and cons of fertility preservation with women with endometriosis. Are there impact of endometriosis in pregnancy and pregnancy outcome? Patients should not be advised to become pregnant with the sole purpose of treating endometriosis, as pregnancy doesn't always lead to improvement of symptoms or reduction of disease progression. Endometriomas may change in appearance during pregnancy. In case of finding atypical endometrioma during ultrasound in pregnancy, it is recommended to refer the patient to endometriosis center with appropriate expertise. Complications related directly to pre-existing endometriosis lesions are rare, but probably underreported. Such complications may be related to their decidualization, adhesion formation, stretching, and endometriosis-related chronic inflammation. Although rare, they may represent life-threatening situation that may require surgical management. Clinicians should be aware that there may be an increased risk of first trimester miscarriage and ectopic pregnancy in women with endometriosis. Clinicians should be aware of endometriosis-associated complications in pregnancy, although rare. Prevention of recurrence of endometriosis. When surgery is indicated with women in women with an endometrioma, clinicians should perform ovarian endometrioma, ovarian cystectomy instead of drainage and electrocoagulation. For the secondary prevention of endometriosis-associated dysmenorrhea, dyspareunia, and non-menstrual pelvic pain. However, the risk of reduced ovarian reserve should be taken into account. Clinicians should consider prescribing post-operative use of levonorgestrel-releasing intrauterine system or combined hormonal contraceptive for at least 18 to 24 months for the secondary prevention of endometriosis-associated dysmenorrhea. After surgical management of ovarian endometrioma in women not immediately seeking conception, clinicians are recommended to offer long-term hormone treatment as combined hormonal contraceptive pills for the secondary prevention of endometrioma and endometriosis-associated related symptom recurrence. For the prevention of recurrence of deep endometriosis and associated symptoms, long-term administration of post-operative hormone treatment can be considered. Clinician can perform ART in women with deep endometriosis as it doesn't seem to increase endometriosis recurrence per se. Treatment of recurrent endometriosis, any hormone treatment or surgery can be offered to treat recurrent pain symptoms in women with endometriosis. Fertility preservation. It is recommended that adolescents with endometriosis are informed of the potential determinantal effect of ovarian endometriosis and surgery on ovarian reserve and future fertility. Fertility preservation options exist, and it's recommended that adolescents are informed about them, although the true benefit, safety, and indications in adolescents with endometriosis remain unknown. Before and after surgery for endometriosis, those individuals who wish to become pregnant should be counseled objectively on their subsequent chances of achieving a pregnancy. To this purpose, the endometriosis fertility index was developed as an end-of-surgery scoring system that predicts non-ART pregnancy rates, natural conception, or IUI after surgery. It was delivered from prospective analysis of clinical data, has since been externally validated in over 30 studies. By scoring patients-related factors as age, duration of subfertility, history of period pregnancy, and surgical factors as function of tubes, ovaries, endometriosis lesion, and total score as extracted from the revised Asram staging. A score between 0 and 10 is generated. This score is strongly correlated with post-operative non-ART pregnancy rates and can therefore be used to counsel patients on their reproductive options, although it assumes normal gamete function. It's highly reproducible, further support its use as an important clinical decision tool. This is endometriosis fertility index, depend on the age, depend on the history, depend on, as you see, the function of fallopian tube, fimbria, and ovary. When used as a system to decide on post-operative ART, healthcare costs have also been shown to be reduced through optimal patient selection. Additionally, as it has been shown that the end of surgery endometriosis fertility index can be estimated accurately prior to surgery. This estimation could be used as an instrument to guide joint physician-patient decision-making between surgery, ART, or other fertility management options for the individualized treatment of women with endometriosis-related infertility. And many thanks for your attention.
Yeah, thank you, Dr. Shadi, for such an excellent lecture. We have received one question. Will you stop sharing the screen?
Okay.
Yeah. So this question you can also see in the chat box.
Yes.
So, yeah.
According to guidelines, there is no difference between drugs of induction of ovulation, HMG, recombinant FSH, highly purified FSH or purified FSH. There is no difference between all. You can use the cheapest one. But at the past, we use the ultra long protocol for cases of endometrioma. But now there is no difference. No one now use ultra long protocol. We use only long protocol and antagonist protocol. For me, I use antagonist protocol for all cases for more than 10 years.
Correct. Yes, antagonist protocol gives the very good results.
Yes.
So we have received one, we have received one more question from Dr. Harita. Yeah. Regarding the indications of laparoscopy in endometrioma regarding to size.
Firstly, you must know, you must ask the patient about the complaint. What is the main complaint of the patient? If the main complaint is infertility, please don't touch endometrioma. But if the lady complete her family and the main complaint is pain, you can do laparoscopic cystectomy. So you can do laparoscopy in a specific situation according to patient age, according to the anti-Mullerian hormone, antral follicle count. If the lady has, if the lady is PCOS and AMH is very high and very high antral follicle count, yes, you can do if the endometrioma is huge. But if the lady AMH is 1 or 2, if you do laparoscopic cystectomy, you will decrease the anti-Mullerian hormone for this lady, and you will do iatrogenic premature ovarian failure. So for me, the main advice in cases of endometriosis associated infertility, please don't do laparoscopy. Do directly IVF, and after the lady complete her family, you can do cystectomy.
Yeah, thank you. Yes, you have very rightly pointed out the very correct point. Yes, because so many times the excessive use of the electrocautery destroys the more follicles. So yes, it will cause more damage. So more reduction in the AMH, the chances of POI are high. So now the another question is from Dr. Apurva Asthana. Dr. Apurva.
There is abuse for laparoscopy in cases of infertility.
Correct. Yeah. Correct. So we will take another question from Dr. Apurva. Trigger to give, as in many cases, the follicles don't rupture. So what do you prefer for the trigger in the patients of the endometriosis?
Induction of ovulation, you can use any medications, HMG, FSH, purified FSH, recombinant. I use cheapest one, HMG. I use HMG for all cases as this is the cheapest one. So there is no difference in pregnancy rate or live birth rate between the different types. According to protocol, the same long protocol and antagonist protocol, there is no difference between pregnancy rate and live birth rate.
I think she's asking that what you are giving for the rupture. So what you are preferring in these patients, the HCG, or you are preferring the leuprolide? What you are preferring?
Yes, we use HCG
for the rupture of the follicles. Yeah,
yes.
usually the recombinant HCG gives very good results. Okay, yes. Now we can take another question from Dr. Sanna Sagar. How to give patients induction of ovulation in ART with endometrioma? I think just now he has discussed. Yeah.
Yes,
Okay.
we answer this question.
Now,
You can give the
okay.
lady agonist or antagonist with the cheapest drug of induction of ovulation. I use HMG for all cases.
So another question is from Dr. Harita. What to do if the patient is infertile and has ureteric endometriosis with hydronephrosis?
I will send this lady for a specialized endometriosis center to do laparoscopy for this case, and after that, we can do IVF for her. There is no relation between infertility and ureteric endometriosis.
Correct. So friends, don't hesitate to take the help of our colleagues. So everything we can't treat, wherever is required, we can take the help of the opinion of the urologist also, endocrinologist also, and surgeons also.
Yes.
So thank you, Dr. Shadi. There's one more question from Dr. Yajini. Yeah, hi, Yajini, madam. She's writing, how do you tackle recurrent endometriomas?
Endometriosis is a chronic disease. So after removing of the endometrioma, it's normal to find a new endometrioma, maybe in the same ovary or maybe in another ovary. We talk about how to manage recurrence of endometrioma. We give the lady, if the lady complete her family, we can give her combined contraceptive pills continuous, especially if there is pain.
Do you use the cabergoline in the cases of the endometriomas? Have you find some good results?
I don't have any information about cabergoline.
Okay. Besides this, we have got lot of appreciations at the YouTube as the program has gone live in the YouTube. So thank you, Dr. Shadi, for sharing your knowledge with us. As usual, your lectures are always very informative. And thank you, dear friends, for joining. And the series is come back now. So now on the next week, we are going to discuss about the recent guidelines of PCOS. So stay tuned. Next week, I am doing on the Wednesday. After that, every Thursday. So I will post the flyer soon. So thank you once again for everyone for joining. Thank you, Dr. Shadi. Thank you. Thank you, Sahiti, and thank you, Shield Pharma, for providing the platform.